Assalamu alaikum. Today we'll be starting with the adrenal disorders, and we'll be having three lectures in a series of lectures on adrenal disorders. Now, before we start on to the case scenario or disease pattern, we just have a recap of what adrenal glands are and what how do they function and what is their. So, as already studied in your physiology and then in anatomy, that adrenal glands are lying over the top of both kidneys, and they are strongly a circular type shape and a small gland which has two parts, which is the central part is its medulla and the peripheral part is called the adrenal cortex, and they both have distinct functions. Now the adrenal medulla, which we'll be discussing in some next lectures, is primarily responsible for production of catecholamines, which include epinephrine, norepinephrine, and a very small amount of dopamine. And these are primarily sympathomimetic agents which act on the receptors and then lead on to increase in the heart rate or increase in vascular tone and regulation of blood pressure. And then there are certain other functions as well. But adrenal cortex is a totally separate, kind of a gland, which is actually truly an endocrine gland. This comprises of three layers or three, strata. The outermost is the glomerulosa. The middle one is the this is zona reticulosa, and the inner one is the zona reticulosa. And the middle one is called zona fasciculata. So this is what how it is abbreviated: GFR, glomerulosa, fasciculata, and reticulosa. The outermost portion, which is shown in yellow, is zona glomerulosa, and it secretes mineralocorticoids, and the mineralocorticoids are associated with the regulation of water hemostasis through regulation of electrolytes, primarily sodium and potassium. The middle part, which is fasciculata, this secretes glucocorticoids, and as the name suggests, gluco, something to do with the glucose, and corticoids with the corticosteroid hormones are in this cortisol, and this is responsible for glucose hemostasis. And then there are many other functions which include the immune system, which include the certain other metabolism regulations. They all are. The third portion is zona reticularis, which is responsible for production of sex hormones, primarily producing androgens, but maybe a little amount of estrogens as well. Now, the adrenocortex, as we have just reviewed, there is a mineralocorticoid producing adrenal, which regulated through the angiotensin receptor and renin-angiotensin systems. There is, glucocorticoid producing adrenal cortex, which is regulated through adrenocorticotropic hormone ACTH secreted from the anterior pituitary. And then there is an androgen producing adrenal, which is regulated through sex hormone levels. This is the, in nutshell, the how this various hormones are secreted or produced, in fact, by the various layers. So if you go on to this, there are three zones: glomerulosa, fasciculata, reticularis, and then there is a central portion. Now the main substrate for the production of these hormones is cholesterol. So cholesterol does not have only bad things to do; it has very important function to perform in the body. This cholesterol in the mineralocorticoid producing area is acted upon through cholesterol desmolase, and this then derives into pregnenolone. This undergoes beta hydroxylation through dehydrogenation, produces progesterone. Then a 21 hydroxylase production, hydroxylation producing 11 deoxycorticosterone, and then 11 hydroxyl which produces corticosteroid, and finally this aldosterone synthetase makes it to aldosterone. So this is the pathway the cholesterol take in the mineralocorticoid produces, and it undergoes hydroxylation of at different positions. First one at the 17 hydroxylase alpha position, then 21 hydroxylase, then 11, and then finally. So any of the deficiency of any of these hydroxylases would block the further synthesis and divert this to the secondary pathways. Now this pradopregnenolone then again undergoes hydroxylation 1720 and 3 beta hydroxylation, and this with 21 hydroxylase and deoxycortisol, and then 11 beta hydroxylase. This produces cortisol into the glucocorticoids. So the pathway from here to here is common pathway, and then the similar this hydroxylation then leads on to production of glucocorticoids. Into the zona, say, reticulosa, this 1720 hydroxylation would lead on to production of dehydroepiandrosterone, and then further two hydroxylations, 3 beta and 17 beta of this, and would lead on to production of testosterone, and this aromatase and 5 alpha reductase then would lead on to production of estrone or production of estradiol or dihydroestradiol. Now this is again explaining that the primary substrate remaining in the cholesterol, there are various hydroxylation of this cholesterol after this cholesterol desmolase has converted pregnenolone, and this is in, if it is in the glomerulosa, the end result is production of mineralocorticoids. If it is in the fasciculata, there is production of glucocorticoids, and if there is in the reticularis, it is production of the androgens. And any of blockade of any enzyme, we're talking about certain say diseases where these enzymes are deficient, and this lead on to an excess of either say estrogen producing excess or androgen excess or glucocorticoid excess or mineralocorticoid responsible for an disease or pathologies accordingly. So adrenals are regulating or regulated through salt, through sugar, and through sex, all three S which are responsible for the primary function of adrenals is to regulate these hormones responsible for regulation of salt, regulation of sugar, and of the androgens or estrogens, or regulation of the sex hormones. With this background, now we talk about a case scenario of our first case, which is a 40-year-old man who presents to his primary care physician with 1 year long history of fatigue, lightheadedness, muscle weakness. He has lost 5 kg of weight over this time, and he has also noticed that his knees, particularly kneecaps, they are getting darkened or pigmented. He also complains of lightheadedness, and this is particularly severe when he gets out of his bed in the morning, or when he gets up from a sitting position from the chair or bed. And during the entire interview, patient appears a bit irritable and agitated. Right. So his blood pressure was recorded in sitting position, which was 115/75 in a lying position, and in standing position it was 90/60. So there is a postural drop in blood pressure. Patient had markedly thin, lean, or cachectic. He had pigmentation in the palmar creases. He had pigmentation around the elbows, knees, gums, and even the buccal mucosa showed some pigmentation. The lab reports suggested that he has a prominent eosinophilia, His sodium was quite low, and paradoxically his potassium was high, and his blood sugar level was fasting level was 64 milligram per deciliter. So he had some hypoglycemia, hyperkalemia, and hyponatremia. Now, as we said, this is something wrong with the salt and water. There is something wrong with the sugar, and there has been fatigue and pigmentation and all that. So all in all, this suggests that, as we just noticed, that the adrenal gland is responsible for regulation of sodium water balance and sodium and potassium balance, and it also has something to do with the maintenance of blood sugar level through production of cortisol. So the primary diagnosis possibly is adrenal disease, and adrenal disease is probably the adrenal is functioning less or renal insufficiency. Sometimes patient with neuropsychiatric illness like chronic fatigue syndrome can present in similar way. Sometimes these patients are labeled as having depression, and sometimes simple eating disorders like anorexia nervosa can lead on to the picture which mimics this maybe hypoadrenalism. Now, the name given to this disease, which is because of the lack of adrenocortical hormones in total, is Addison's disease. Now, adrenocortical insufficiency is due to destruction or dysfunction of the entire renal cortex. It can affect both glucocorticoid and mineralocorticoid function, and symptoms would appear only once more than 90% of the gland has been destroyed. Even a small amount of gland, if it is preserved or is functioning, would lead on to probably a normal function, and the symptoms are usually not manifested. Somehow this is more commonly seen in women and children. Mostly the age at onset is usually in 30 to 50 years. It can present earlier in patients who have polyglandular autoimmune syndrome, or who have, as we discussed, congenital adrenal hyperplasia because of certain enzymes being lacking. See, this 21 hydroxylase deficiency or 11 hydroxylase deficiency may be responsible for congenital adrenal hyperplasia. Sometimes it can be long chain fatty acid disease because the primary substrate for the synthesis of these adrenal hormone was cholesterol. So fat disorder, fat metabolism disorder may also present with this. The causes are mostly idiopathic or autoimmune. There is sometimes 80% of the cases which produce or present with symptoms of Addison's or symptoms of hypoadrenalism. They are because of autoimmune destruction of the gland. There may be lymphocytic infiltration or some fibrosis, but in these disorders, in the idiopathic, the adrenal medulla is spared. Sometimes this autoimmune Addison disease may be associated with other endocrine disorders or autoimmune endocrine disorders like Hashimoto's disease. Sometimes it may be associated with polyglandular autoimmune syndrome type 1, where there is, in addition to Addison, the patient also has hypoparathyroidism or may have a mucocutaneous candidiasis as well. In polyglandular autoimmune syndrome type 2, the Addison disease is associated with type 1 diabetes, both being sharing the autoimmune pathology, and then in addition to that, they have Hashimoto's thyroiditis or Graves' disease as well. And can be seen in chronic granulomatous diseases like tuberculosis, sarcoidosis, histoplasmosis, blastomycosis, some cryptomycosis, which can also involve, cryptococcus can involve the adrenal glands, particularly in patients with HIV or immunocompromised patients. Some of the malignancies may be associated with it. And similarly, some infiltrative metabolic disorders like myeloid and hemochromatosis may involve adrenals and can lead on to adrenocortical insufficiency. It should be considered any hypotensive patient who possibly have acquired immune deficiency syndrome, and then there's an Algrove syndrome where is a congenital adrenocortical unresponsiveness to ACTH. Typically presents in childhood. These children fail to thrive. They have low birth weight. They have feature of adrenocortical insufficiency, and they may have presenting with recurrent hypoglycemia. Some of the drugs can also lead on to Addison disease or hypocortisolism or maybe hypoadrenalism. Ketoconazole, which inhibits the adrenal cytochrome P450 steroidogenic enzymes. Aminoglutathione blocks the conversion of cholesterol to pregnenolone by inhibiting desmolase. Mitotane blocks the adrenal mitochondrial steroid biosynthesis. Similarly, busulfan, etomidate, trilostane, they inhibit or interfere with the adrenal steroid biosynthesis, and similarly, methadone may deplete the pituitary ACTH and may cause secondary adrenocortical in some patients. So, whenever we are considering or managing a patient of Addison disease, we have to keep in mind that rarely it may be because of any of these drugs which patient may be using for various indications. The clinical manifestations, of course, as we have already grouped them into glucocorticoid deficiency and mineralocorticoid deficiency and adrenal energy deficiency. So they may be isolated deficiencies or may be combined together. So the glucocorticoid deficiency would present with fasting hypoglycemia, increased insulin sensitivity, muscle weakness, morning headaches, and increased production of POMC or melanin, and there is increased pigmentation in the palmar, creases, gingival border, and axilla. Mineralocorticoid deficiency would present with hypotension. Patient would have dizziness, may have postural in addition to that he may have blackouts on standing up. Now, an important finding is these patients who have mineralocorticoid deficiency, there is salt craving. They have a strong desire to take salt excessively to compensate for the salt which is being lost in their urine as a result of absence of mineralocorticoids. They do have loss of appetite, and the electrolyte abnormalities would include hyponatremia, hyperkalemia, and metabolic acidosis. Deficiency of adrenal androgens, which are more important in men particularly, there would be decreased axillary hair, there will be decreased pubic hairs, there will be loss of libido, and there will be, if puberty, they may be totally asymptomatic. So most of these patients have a very insidious onset, and they have a non-specific complaints. Hyperpigmentation of the skin and mucous membrane is the most prominent features. They complain of darkening of their skin complexion, and this symptom alone may proceed by many months before the other symptoms set in. Now, what happens is that due to lack of cortisol, the pituitary gets feedback that it has to increase its production of adrenocorticotropic hormone. This exacerbates ACTH induced. ACTH also stimulates, in addition to gland melanocytes, to produce melanin. So that is the reason for hyperpigmentation. And this hyperpigmentation is definitely more marked of the sun exposed areas or the extensive surfaces, knuckles, elbows and knees, particularly the mucous membranes and along the gingival margins or buccal areas. And sometimes there is the autoimmune Addison disease may also be associated with autoimmune destruction of the melanocytes, and some of the areas may show hyperpigmentation where ACTH stimulated uh, say melanin production is there, and some of the areas where uh, there is autoimmune destruction of the melanocyte themselves, there may be areas showing hypopigmentation or vitiligo. Or this is an example of a change in complexion over some period from this type of complexion to this type, or a darkening of the skin complexion. This is how this buccal mucosa. This is just light reflection. This brownish type of patches, which are particularly along the inner side of the cheek, they are the one which usually can be examined. Similarly, these gingival lines or gum lines may have a hyperpigmentation. Uh, Inner part of the lips may show hyperpigmentation, and sometimes already existing nevus may have an increased melanin deposition and may show more darkening or blackening of the moles. Uh, the symptoms of dizziness and orthostasis or postural hypotension is because of the lack of sodium being lost, and there is less water retention and patient becomes hypotensive. Myalgias and flaccid muscle paralysis may occur because of the associated hyperkalemia or increased potassium level, and this progressive weakness, fatigue, and appetite and weight loss are the symptoms because of the mineralocorticoid deficiency, and they also lead on to GI upsets like nausea, vomiting, and occasional diarrhea as well. When you examine them, a patient with a long-standing Addison or hypoadrenism or hypercortisolism may reveal increased pigmentation in the skin and mucous membranes, as I already shown, and sometimes it may be associated with some areas of white areas of vitiligo. Patient may show evidence of dehydration, hypotension, and postural hypotension. Females may show absence of axillary and pubic hairs and decreased body hair, and this is due to less of adrenal androgens, which are major source of androgen in women. In men, there is an additional source of androgen in the form of well, the primary source in them is usually the gonads or testicles. The secondary adrenal insufficiency, by secondary we mean that the adrenal itself is okay, but there is lack of ACTH from the pituitary, or there is maybe receptor defect because of the ACTH not acting upon the receptors. Now, the difference between the primary and secondary can be made through two things. That since there is no ACTH in secondary, say hypoadrenalism or secondary Addisons, there is no hyperpigmentation because ACTH is lacking. Whereas in primary Addisons, the ACTH is in excess, and that's why they have increased pigmentation. Similarly, GI symptoms and salt craving are less common because the mineralocorticoid producing area is not under the effect of ACTH, so that's why they would not have loss of sodium or retention of potassium, and they may not have this craving for the salt. How we diagnose? Of course, the primary thing is that we go for low, screen them either through low serum cortisol, or in primary Addisons, the ACTH would be elevated. But as we discussed previously, that in all patients where we have endocrine disorders where we are suspecting hypofunctioning, we tend to stimulate that gland, that whether there is a reserve to produce hormone or not. So this is done through the ACTH stimulation test. There's two types of ACTH stimulation test which are performed. It's a rapid one test, and in rapid test you draw blood in two separate test tubes for the baseline cortisol level as well as the aldosterone level. So after we have checked for the baseline cortisol and aldosterone level, we inject patient with ACTH about 250 microgram or 0.25 milligram intramuscularly or intravenously, and after 30 to 60 minutes after easiac injection, uh, their sample is again drawn for estimation of the cortisol and for the aldosterone levels. How do we interpret these results? There's two criteria. There should be, if the adrenal is functioning normally, the ACTH injection would lead on to increase in the cortisol value of 7 microgram DL or more. And the value must rise around 20 microgram per DL more in 30 or 60 minutes. So this would suggest an abnormal adrenal cortical function and would exclude the diagnosis of primary hypoadrenism or primary Addison. But those who have Addison disease, their basal cortisol and level will be low, and there will be no or minimal change in response to ACTH. So this is rapid ACTH stimulation test. When the results of rapid ACTH test do not meet the two criteria mentioned above, the further testing might be required to distinguish Addison disease from the secondary adrenocortical insufficiency, which means that you may have the ACTH unresponsiveness. In acute renal crisis, where treatment should be not be delayed in order to do the test, a blood sample for random plasma cortisol level is obtained, and patient should be started on the required cortisol hydrocortisone replacement. A random level of 25 microgram per deciliter in patient who are hypotensive or who are in shock or who are suspected of hypocortisolism or Addison should exclude the adrenal insufficiency of any kind. So if you just go for a random check of a serum cortisol level and this level is less than more than 25 microgram, it means that his adrenals are functioning normally and further testing may not be required. The other features which can be say observed, this patient would have hyponatremia, they would have hyperkalemia, there is sometimes some hypercalcemia, they may have say metabolic acidosis, eosinophilia, anemia may be a feature because bone marrow stimulation does require a certain level of steroids and certain glucocorticoids. There is low cortisol, and this does not respond to rapid ACTH stimulation test. But when you are thinking of a secondary renals, these patients, as I said, do not have hyperkalemia or hyponatremia. Their cortisol is low and their ACTH is also low, and hyperglycemia is more common in the secondary adrenal insufficiency. There may be eosinophilia and anemia. Electrolytes we already mentioned. Hyponatremia, hyperkalemia, hypercalcemia are features. Hypoglycemia is very commonly found in these patients. There is low cortisol, which is unresponsive to synthetic ACTH injection or stimulation. Their ACTH stimulation, the cortisol level do not increase in response to ACTH, and this ACTH level is sometimes done to differentiate between primary or secondary, because in case of primary Addison, the ACTH level would be high, whereas in a primary secondary, the ACTH level would be low. And if we think autoimmune cause of sometime adrenal antibodies may also be checked, and in majority of the cases the cause may be either tuberculosis of the adrenal glands apart from being autoimmune. So sometimes adrenal calcification or an ultrasound or X-ray, sorry, and the CT scan may be noticed. The management for these patients with the adrenocortic insufficiency, they always need glucocorticoid replacement therapy usually, but mineralocorticoid may not always be required, and you have to treat the underlying cause or underlying, like if it is sarcoidosis, you treat it, and if it is tuberculosis, again patient would require treatment. The treatment in endocrine disorders, deficiency disorders, is by hormone replacement. This is called hormone replacement therapy. The main hormone which is deficient is cortisol, and the usual required dose of cortisol is around 50 to 20 milligram given orally in morning, and by evening, since the activity level goes down, so the lesser amount is required, which is around 5 to 10 milligram uh, given in the evenings. Flutocortisone is a mineralocorticoid, and if we label that they have a mineralocorticoid deficiency as well, this flutocortisone 0.05 to zero point 0.2 milligram per oral daily may need to be replaced. This is to be remembered that in any case when patient have an acute illness or patient is undergoing surgery, there is an increased demand for the steroids, and steroid dose might have to be increased 2 to 3 fold for a few days during illness or for surgery. As actually what happens is that when they are sick, they stop the medication, and this is the one reason that these patients may be pushed into adrenal crisis. We have to be careful while replacing. There should be close monitoring of any signs of inadequate replacement with the symptom persisting, or an over replacement which make your patient may push him into become cushingoid because of the overdosage. An excess of cortisol may also predispose to osteoporosis. So in majority of these patients, a periodic bone DEXA scan or dual energy X-ray absorptiometry should be done to look for any early osteoporosis developing in these individuals. Patients should be also instructed to double or triple their steroid replacement doses, particularly in stress situations such as common cold, tooth extraction, or infection. Here is a quiz, or maybe do you know that which famous American president had Addison disease? Anybody? The 35th US President John F. Kennedy was having Addison disease and was on hormone replacement therapy for that. Now we have a second case scenario where a 40-year-old female patient who has rheumatoid arthritis and is on 30 milligram of prednisolone daily for past 6 months, and she had fever and cough, and she stopped taking that medication for about a week, and then she presented in the emergency department with complaints of severe abdominal pain, headache, and fever. On examination, her blood pressure was 60/40, pulse was 140 per minute, temperature was 40.6. So what's the diagnosis? We have a lady who has been on steroid for her rheumatoid arthritis for 6 months, and then she suddenly stopped it, and this stoppage then would lead on to that there is since an exogenous replacement of prednisolone has led on to suppression of the pituitary to produce ACTH. Now, if you abruptly stop their exogenous steroids, there would be no ACTH in the circulation to stimulate the adrenal gland to produce the endogenous cortisols. So this acute cortisol deficit state would push this patient into a crisis, and this is called as adrenal crisis, right? Usually it can be precipitated by surgery, infection, or any current illness, and it's particularly more common in patients who are on iatrogenic, who are on steroids for a long time and has suppression of their pituitary adrenal axis, or their ACTH is suppressed because of the exogenous hormones. Approximately 8% of the patients diagnosed with the Addison would require annual hospital treatment for adrenal crisis. Exposure to the gastric infection is the most important risk for adrenal crisis in patient with the Addison disease, and particularly those who have diabetes or asthma. The differential diagnosis of adrenal crisis would include all conditions like acute abdomen, gastroenteritis, or DK, because these may be the symptoms confusing with the adrenal crisis. Usually, it is the abrupt cessation or stoppage of the prolonged high-dose steroid therapy, as in our patient, or withdrawal of a suppressive glucocorticoid therapy. Occasionally, a condition called Waterhouse-Friderichsen syndrome, which is seen in patient sometime with meningococcal coccemia, which results in acute hemorrhages into the adrenal, and this acute say lack of cortisol would push this patient into adrenal crisis of hypotension, and this would be adrenal crisis. Similarly, adrenalectomy would result in patients going into adrenal crisis. The management of adrenal crisis would be that it should be an immediate IV access should be established urgently. These patients should be started on infusion of isotonic saline to restore the volume and correct the hypotension. And sometimes you may have to give glucose as well, because they do develop hypoglycemia as well. The precipitating cause should be sought and corrected where possible. You have to administer around 100 milligram hydrocortisone in 100 cc of isotonic sodium chloride solution by continuous IV infusion at a rate of around 10 to 12 cc per hour, and infusion may be initiated with 100 milligram of hydrocortisone as an IV bolus. So you give a bolus of 100 milligram of cortisone stat, or diluted in 100 ml of saline over a period of say at a rate of around 10 to 12 cc per hour. The clinical improvement, usually especially blood pressure, would start responding within 4 to 6 hours. After 2 to 3 days, this stress cortisone dose should be reduced to around 100 to 150 milligram infused over a 24-hour period, and this would at least avoid the stress-induced GI bleeding. And as the patient improves, then he should be shifted on to gradually tapered from the continuous infusion to the daily replacement dose of, which is usually 3 milligram per hour, and eventually to daily replacement dose oral intake when it is possible. During surgery in these patients who have Addison, you set up a continuous IV infusion of 10 milligram per hour of hydrocortisone, and maybe some IV boluses may be given to avoid hypotension developing during surgery. After the procedure, you continue this hydrocortisone infusion for 24 to 36 hours, and then gradually shift back to their oral medication, and mineralocorticoid replacement may be withheld until the patient remains on the daily replacement steroids. The patients with adrenal insufficiency, particularly if they want to conceive or to have pregnancy, you have to be careful, because conception, fetal development, delivery may be problematic if they are not treated properly. But if treated properly and on a regular replacement therapy, it should not be a problem. Sometimes the nausea, vomiting, and in the first trimester, or this hyperemesis gravidae may require to increase in the dose of steroids or dexamethasone. and some patients may require slightly more glucocorticoid in third trimesters. During labor, again, there is should be patient should be adequately hydrated. Cortisol should be administered every 6 hourly, and at the time of the delivery of the labor, if labor is prolonged, parental hydrocortisone around 100 milligram every 6 hourly may be given or may be given as a continuous infusion. And after the delivery, this dose can be quickly tapered to the back to the maintenance dosage every on over 3 days. If you fail to recognize this Addisonian crisis, it may be life threatening, but if treated promptly and effectively, this has a good say prognosis. And sometime this adrenal crisis may be provoked by uh, adrenal hemorrhage or in setting of acute event superimposed on chronic inadequate adrenal cortical insufficiency, and that should be kept in mind. Thank you very much for your attention, and we'll next time we'll be going on to uh, management this hypercortisolism or Cushing's.